Thank you all for joining us for today's webinar, Advanced LARC Topics for Providers, Immediate Postpartum LARC Workshop, Part 1. My name is Jessica Monmany, and I'm the Senior Education Associate at ARHP. I'll be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You are also welcome to use the chat and question box to ask questions throughout the webinar, which our presenter will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Catherine White, today's presenter. Dr. White is an assistant professor at Boston University School of Medicine. She received her bachelor's degree from Duke University, her MPH from Columbia University School of Public Health, and her medical degree from the University of Medicine and Dentistry of New Jersey. Dr. White has received numerous awards for her education and research in obstetrics and gynecology. We're thrilled to have Dr. White with us today, and I will hand it over to her. Dr. White, you have the floor.
Thank you so much, Jessica. First, I just wanted to say how grateful I am to the folks at ARHP for allowing me to have this opportunity to talk about something that is really near and dear to my heart. And I'm thankful to all of you listening today and taking the time out of your completely hectic, crazy clinical schedules to learn about something that may be completely new to you or something that you may know something about but want to learn some more. So a quick acknowledgement of commercial support. The project and the webinar are funded through an independent educational grant from Actavis, Bayer, Merck, and Medicines 360. There are a couple of disclosures from the folks who are on the committee that create these webinars. I just want to highlight my own disclosure, which is that I use a levonorgestrel IUD that I received postpartum. That may influence how you receive the information that I'm giving you today. So our learning objectives for today are to talk about the benefits of immediate postpartum LARC, or IPP LARC, to discuss the data supporting the safety and efficacy of IPP LARC to address patient concerns, and to identify ways to address obstacles impeding the uptake of IPP LARC programs, including financial, administrative, and medical issues. And I want to start with a patient story, Galena. She is a real patient of mine, though this is not her real name, and thanks to Google Images, this is not her real picture. She was a 36-year-old Gravida 5 Para 4 who presented to our labor floor in active labor demanding not an epidural, not that there would be no medical students in her room, but that she get a tubal ligation after she delivered. Upon questioning, we found out that she didn't get her desired tubal after her last delivery because of a mild postpartum hemorrhage. She then unfortunately became pregnant 1 year later. She went on with us to have an uncomplicated vaginal delivery, then very hopefully remained NPO as the hours went by, hoping for her surgery. And as happens only too often, the labor floor was very busy with emergencies throughout her entire hospital stay, and by the morning of postpartum day 2, she has still not gotten her tubal ligation. So this is my first question for those of you who are listening on the line. What would then happen to Galena at your hospital? A, she would wait until labor and delivery calms down to go to the OR, even if it delayed her discharge. B, she would go to the main OR with either her obstetrician or the GYN team. C, she would be discharged home on Depo-Provera or progesterone-only pills. Or D, she would be offered immediate postpartum LARC. I'm sorry, that last option did not make the poll. I would love if people had actually gotten to choose that one, but my guess is that it might be one of the other 3 anyway. We'll give everyone a little bit of time. I am very impressed that anybody's hospital would allow a patient to delay their discharge until she gets her tubal ligation, but that's pretty wonderful. And it's awesome for those of you who have a GYN team or other obstetricians available who could take this patient to get the surgery she needed. but I'm not really surprised that the majority of people would have to discharge her home on a shorter acting contraceptive than the method that she really wanted. I'm going to try to advance the slide. So first I want to talk about the benefits of immediate postpartum contraception. The last few years have brought us great improvements in unintended pregnancy rates in the United States among all women and also particularly adolescents. But the disparities around unintended pregnancy have grown, and the burden of unintended pregnancy now more than ever falls mostly among poor women. One subset of unintended pregnancy is often rapid repeat pregnancy, or RRP. These pregnancies have different definitions depending on which data set you look at and which investigators are describing their work, but in general it refers to a pregnancy that occurs within 18 months of a previous birth. Roughly 1/3 of all pregnancies in the U.S. are a rapid repeat pregnancy. And while some families may welcome or even plan to have children close together, most women who have these pregnancies that are this close together are mistimed or unwanted. And in one survey, half of women who were responding reported having had an RRP at some point in their reproductive lives. And so not only are 1/3 of all pregnancies rapid repeat, but in the U.S., over half of all unintended pregnancies occur within 2 years following a delivery. And the problem is often worse for adolescents as well. Some lay people might think that teen moms have the best incentive to not get pregnant again, but all of us who take care of adolescents who have been pregnant know that the risk factors for having a teen pregnancy don't go away when their placenta delivers. So among adolescents who give birth, between 12 and 49% are pregnant again within 1 year. And the risks of rapid repeat pregnancy go beyond just the sleepless nights with having 2 under 2 at home. There are serious risks to both the mom and the infant with preeclampsia and preterm labor on the maternal side, and severe prematurity, low birth weight, and even stillbirth on the infant side. An interpregnancy interval, the time between the first delivery and the conception of the second pregnancy, this interval of less than 6 months is associated with the highest level of adverse perinatal outcomes, and outcomes in general are even worse for adolescents. Compared with the first teenage birth, a second almost triples the risk of preterm delivery and stillbirth. And adolescents who have more than 2 children within 5 years are more likely to rely on welfare, forego their education, and bear additional children in a short time. So most providers are aware of the benefits of birth spacing, but these benefits are not always reflected in our counseling. Very often providers will tell patients just to delay sexual activity until they come back and see us at the postpartum visit when we can talk about their whole spectrum of birth control options. But most women, roughly 40 to 60%, will resume sexual activity prior to seeing us for that postpartum visit, especially adolescents, especially couples who are living together, and especially women who've had a C-section instead of a vaginal delivery. And non-breastfeeding women can ovulate as early as 25 days postpartum. The average woman will ovulate around 39 to 40 days postpartum, and 40% of your patients will have ovulated by 6 weeks, so by the time they see you. And a lot of women and some providers may think that breastfeeding is going to provide sufficient contraception. But as many of us know, lactational amenorrhea as a method of contraception is not the same as exclusive breastfeeding. Then if you add on the number of working mothers who have to start pumping their breast milk when they go back to work, the pump has just simply not been studied when comparing to exclusive nursing as a contraceptive method, which is, of course, grossly unfair to those of us who go back to work and are desperate to try to pump as much breast milk as we can away from the babies. So the problem then should be sort of easy to solve in theory, right? We just have to get contraception accessible to people who want it. But there's a whole slew of issues with trying to get birth control to women who want it and are eligible for the methods that they want. The first barrier, as most of us know, is a low show rate for postpartum visits, especially among the women who are most at risk of unintended pregnancy, whether it is childcare issues, transportation problems, or communication with their providers around when their appointments actually are. Then as many as 1/2 to 2/3 of women who request a LARC method at their postpartum visit won't get it. Either the LARC methods aren't available in the office, an office has 2-visit protocols, or women have an insurance change 6 weeks out. So this is a really common problem of women who plan to get an IUD or an implant after they go home from the hospital and then having problems actually accessing it. There's a similar problem with women who want postpartum tubal ligation. Roughly 50% of women who request a tubal won't be able to access it, generally for the kind of systems reasons that plagued Galena, my case at the top of this webinar. And then nearly half of women who are denied a tubal ligation will be pregnant again within a year, just like my patient. The immediate postpartum period then really has some fairly unique and convenient timing. You have a captive audience with a patient who is still inpatient. The providers are very often available, having just attended the delivery, and patients are often very motivated. One survey of 800 women showed that the average amount of time that women wanted to wait was 2 years before becoming pregnant again. And most women will remain insured throughout the immediate postpartum period. That might not be true for the postpartum visit, but certainly throughout their hospital course. Then women who receive counseling during the postpartum period have been shown to have increased rates of contraceptive use and fewer unplanned pregnancies. So let's look at some of the data behind immediate postpartum LARC. We know that LARC is particularly well suited to meet the needs of new moms. Highly effective, it's reversible, and really important with a newborn at home, it's forgettable. So looking at the efficacy of IPP LARC, first, there's no reported difference in efficacy when the devices are placed immediately postpartum. The implants and the IUDs should work just as well as they do when they're placed in the office. And LARC has been shown to really help women achieve birth spacing. There was a cohort of over 100,000 women in California who was studied, and the investigators found that women who used postpartum LARC had almost 4 times the odds of achieving an optimal birth interval when compared with women who used barrier methods alone. And LARC method and women who used pill patch or ring had almost twice the odds of an optimal birth interval. So we know that any contraception is still going to help with birth spacing, but LARC methods, like in so many studies, are shown to be really superior. And this is even more powerful for adolescents. The odds of rapid repeat pregnancy decrease when a device is initiated immediately postpartum. And a study of 400 adolescents showed that the rate of rapid repeat pregnancy went from 18.6% to 2.6% in the first year postpartum. And non-implant receiving teens were 5 times more likely to be pregnant again 1 year later. Now, very often these studies are small data. Often the studies around efficacy are secondary analysis. We don't have any great large prospective cohort data to see what happens to rapid repeat pregnancy rates outside of the adolescent populations. That actually is one of the holdups for many states who are considering adopting IPP LARC policies, is that the data right now for large-scale movements in unintended pregnancy rates for immediate postpartum LARC placement is lacking. When looking at continuation, we see that there's either equivalent or greater IUD and implant use among immediate postpartum placement patients than among intended interval placement at both 6 and 12 months. And of course, the key word there is intended, because so many women plan to get an IUD or an implant postpartum and then don't. The satisfaction rates tend to mirror the continuation rates, so patients tend to be very happy with their methods. And elective discontinuation for both the IUDs and implants are on par with interval placement. So patients are not more likely to discontinue these methods when they're placed immediately postpartum. So my second question for the audience, just to kind of get a sense of what you might have heard about devices, is that question, there's an increased risk of postpartum hemorrhage after immediate postpartum IUD placement. True or false? You know that LARC methods tend to attract a lot of statements and sometimes mythology around them, especially on the interweb, and patients will often come to us with concerns. Frankly, I would wish our patients would come to us with their Dr. Google concerns more often. So yes, it is false that there is any kind of risk of increased hemorrhage, which is one of the very happy things we get to share with patients when counseling them about this. So first, we're talking about safety. I want to talk about a Cochrane review that was first performed in 2010 and then updated in 2015. And the review, the assessment of the reviewers is that immediate postpartum LARC was safe and effective. And when talking about IUDs, there was no increased risk of infection, perforation, or bleeding. They did note the higher expulsion rates for postpartum placement versus interval IUD placement. And they also noted that the use of particular instruments, manual insertion, or IUD modifications did not change expulsion rates. Based on very small data, there's some suggestion that using ultrasound may decrease perforation risk, but they talk very much a lot about the convenience for both the woman and her clinician. And their conclusion is essentially that the benefit of effective contraception immediately after delivery may outweigh the disadvantage of the increased risk of expulsion. So I think that's fairly powerful words in the Cochrane group. Then when looking at the CDC medical eligibility criteria about how the CDC views both IUDs and the implant, as a quick reminder, when the MEC rates medication or birth control method a category 1, that's for no restriction for the use of the method for women with that condition. And a number 2 is that the advantages of using the method generally outweigh the theoretical or evidence-proven risks. And what you can see is that for both IUDs and the implant, they are rated a 1 or a 2, both in the immediate post-placental period, less than 10 minutes after delivery, in that 10 minutes to 4 week period, so sort of the time the hospital discharge would be involved in that window, and then it goes down to a 1 over 4 weeks. The only real contraindication that the MEC talks about is infection and sepsis around the time of delivery. We'll talk a little bit more about breastfeeding later, but you can see that even with breastfeeding moms, the implant and the IUD are both considered safe. All right, so some of you may be raring to go at your institutions when you hear all this data about how great postpartum LARC can be. But before you get too excited and start to hit into the walls, I want to review the obstacles that you might face as you begin such a journey. Forewarned is forearmed, as they say. So the first challenge, obviously, is going to be financial. So let's pretend for a minute, in an alternate universe, you are a hospital administrator, and it is your job to make sure that your budget is met and that your department at least breaks even, or in rare cases is profitable. Deliveries are great for a hospital. You generate income with the future patients that you raise, as well as the money around the bundled payment for delivery. But all services for a basic pregnancy are wrapped up in that one flat fee that the hospital receives after delivery. So there really is an incentive for the hospital to just do only the necessary services during the time that the woman is pregnant and under their care. The code involves everything through the immediate postpartum period and involves anything related to the birth that happens during the hospital. Now, a lot of us would vociferously argue that contraception is not related to birth, but somehow that has not found the same ground as, let's say, an appendectomy, which is not considered related to the birth, but somehow contraception, because it's going to the same place in some cases that the baby just was, is lumped in with considered sort of part of the birth cost. So let's take two scenarios. In the first scenario on the left, your hospital has magnanimously decided to start an IPP LARC program, and you provide this, let's say, for women who are likely to engage in risky behavior post-pregnancy, they're unlikely to return for their postpartum visit, and the hospital recognizes that this is the ideal time to give these women long-acting, reliable birth control. But under the current reimbursement schedule in many places, any birth control provided by the hospital is not compensated outside the flat fee for the pregnancy. So depending on how you look at the numbers, the cost of the hospital is anywhere between $500 and $1,500. In the second scenario, where the hospital-based clinic makes patients come back postpartum, the hospital will then profit because they can bill separately for the IUD and the insertion and generate another $500 to $1,500 to the hospital. However, for the women who don't return, or the women who are engaging in unprotected sex between the birth and the 6-week postpartum visit, there are going to be unplanned births that will cost a lot of money to the state each year, but because the state's budget is so separate than the hospital's budget, interests don't really align financially when it comes to this issue. So there are a lot of really hardworking people at the state levels who are working on making these connections more clear. So it is true that a lot of private insurances actually will provide coverage for patients. So if you are dealing with a commercially insured population, you may find out that if you call the major insurers who insure your patients, that they actually do have coverage for postpartum LARC and implant and IUD insertions. The issue tends to arise for most of us with Medicaid funding. But even here, there's a difference between coverage about insertion and coverage of the device. In many places where the state is not clearly covering IUD insertions, they do actually cover the insertion process. They're just not clearly covering the device, which of course, though, is the most expensive part of the whole process. And there are varying state Medicaid policies around coverage of postpartum LARC. For good or for bad, the Centers for Medicaid and Medicaid Services have given their consent for each state to handle reimbursement for immediate postpartum LARC. They let each state create their own policies depending on how they want to with regards to reimbursement mechanisms, which has led to very varying approaches across states that have tried to take this on. And they very much want the states to figure out ways to cover immediate postpartum LARC, and they've actually sent statements to the states directly encouraging this. But encouragement from CMS and actually figuring out how to cross this hurdle, we know, are two different things. So a great study was done out of researchers from Michigan looking at what states are doing. Do they have separate or increased bundle payments? Is there an additional payment for the delivery and the insertion? Is it an increased overall payment for delivery services? And found some varying ways to go. Some states reconcile at the end of the year, some reimburse using a special modifier, some allow inpatient use for outpatient codes, which in some cases is the easiest way to go. So for as complicated as this is, though, 19 state Medicaid programs now reimburse for an IUD or implant inserted immediately after a woman gives birth, and 8 other states are considering such reimbursements. And so we've really come incredibly far over the last 4 years, when only intrepid South Carolina led the vanguard towards Medicaid coverage for LARC devices while women were in the hospital. So when trying to figure out how to jump over all these hurdles, with commercially insured patients, it's a little bit simpler. If the insurance will cover postpartum insertion, but the issue is solely the device, many commercially insured patients are able to procure a LARC device directly through their insurance. I actually know practices in New York City that in their GYN offices they don't stock IUDs because they're not getting reimbursed the full cost of the device, and so patients all come in with the device procured directly from Blue Cross or Aetna or Cigna. And so if it works for patients on the outpatient side, it should easily work for patients on the inpatient side. For publicly insured patients, you need to be a little bit more creative at working with your hospital. And what we had done at one of my previous hospitals was our hospital-based pharmacy stocked LARC devices, and the residents and the attendings would write prescriptions for the IUD or the implant in the 3rd trimester of pregnancy, and the patient would just go pick it up at the pharmacy. She'd put it in her baby bag and then bring it to the hospital with her when she came in labor. This process is colloquially known as brown bagging. So if you want to talk with your pharmacy about how your hospital feels about this process, that is sort of the shorthand of what I'm talking about. There's a related workaround called white bagging, which is where you send the prescription to the outpatient pharmacy, but the pharmacy staff deliver the device to labor and delivery. This takes care of concerns around temperature and how the devices are stored. So instead of delivering a device to a patient when you don't know if she's going to leave it in her hot car overnight, the hospital sort of always maintains their hands on the device until it's in her body. But this involves then using the outpatient pharmacy as opposed to inpatient pharmacy. And so in a lot of places they have found this a really effective workaround when you're not able to actually stock IUD devices in your Pyxis or on your labor floor. So compared to the financial hurdles, the other hurdles I'm going to talk about may seem to be a lot simpler. So administrative hurdles with the administration on labor and delivery at your hospital tend to focus beyond just the financial concerns we talked about already, but around the need for new protocols and the need for new staff training. And when you're trying to start a venture like this, you do not have to go through it alone. ARHP and ACOG have protocols available to give you to be able to create your hospital guidelines. You can start with what other folks have used in creating your own. And then it is a matter of staff training like for anything else. One of the best things you can do is identify some labor and delivery nurse champions of nurses who think this is a great idea to help smooth the way as you start a new project. We talk to nursing and in-service meetings to try to get a lot of nurses sort of on board or at least informed at the same time. And then you can work on things like instrument procurement and making it simple. A lot of labor and delivery or postpartum units have small kits made up, both for Nexplanon insertion and for IUD insertion, which has all the things that you need that wouldn't be available on the delivery cart, that people can just grab from the stock room and go, as opposed to, oh, I have to find 6 different things from 4 different places. So when talking about nursing concerns, when I first started this program at my previous institution, one of the biggest concerns that the nurses had was patient discomfort. That you have a patient who's just gone through labor and delivery. The last thing in the world maybe that we want to do is put an IUD in her uterus when she's still so sore from delivery, especially in the 2 days postpartum if you can't get it in postplacentally. Of course, they're very realistically worried about the extra work for labor and delivery or postpartum staff. Most hospitals I know, they have shortages of nurses on L&D. The ratio of nurse to patients is, is lower than ever, and they're worried about what this means for the workflow around a very busy, already busy delivery and work shift. The last, of course, are also lactation concerns, which some of you may be thinking, actually, those are the biggest concerns in my institution, much bigger than anything else that we've talked about today. So my third polling question is around breastfeeding. What impact do you think that the immediate postpartum implant has on breastfeeding? A, reduced milk production, B, shorter duration of breastfeeding, C, a greater need for formula supplementation, or D, no impact? We'll give everybody a minute to weigh in. Okay, happily, answer D is correct, that there is no impact. I'm going to talk about some of the evidence behind that in a moment. So there were 2 systematic reviews and 2 randomized trials looking at this issue around the implant and breastfeeding. Both systematic reviews found that there was no difference between interval implant placement and immediate postpartum placement for overall breastfeeding performance and for infant growth and development. And they looked at multiple markers of milk production, milk quality, frequency of nursing. Every measure they could look at, there was no difference between interval placement and immediate postpartum placement. There were 2 randomized trials totaling almost 100 women, and these found that there was no difference in milk production, in lactation failure, in formula supplementation, or in milk composition, and that in no way that they measured did it impact milk production or newborn milk intake. And one of the most important stats of all is that there's no difference in breastfeeding rates through 6 months postpartum. So there's not a plethora of evidence. There aren't 12 trials looking at this issue. I think as postpartum LARC becomes more available, we will probably start to see more evidence, or at least more studies looking at this question. But as postpartum LARC programs are still ramping up, there haven't been a lot of studies of this question. But it is really reassuring that there is no suggestion of evidence that the implant hurts breastfeeding at all. That said, many of the lactation consultants who work in your hospital may not be aware of such information. So there was a survey performed of 194 lactation consultants who were recruited at the California Breastfeeding Summit. And the majority of lactation consultants felt that the theoretical or proven risks outweighed the benefits, or there was an unacceptable health risk for most progestin methods given after delivery. The progestin-only pill, they said, risks outweighed benefits 76% of the time, for depot injection 90%, and for the implant 93%. And that's if these methods were started within 21 days of delivery, not just in the hospital. And only 30% of these lactation consultants knew about the CDC medical eligibility criteria. So in essence, they were ranking these methods 3s when in fact that's not what they are ranked. And so I talked about the slide earlier about how the CDC MEC looks at the implant and breastfeeding, how it's a 2 for breastfeeding women and a 1 for non-breastfeeding moms. But actually under, that's graph perfect, you'll see that the implant is ranked the same, or rated the same as depot and progesterone-only pills. They are all considered a 2 for breastfeeding women, which means that the implant is no more dangerous than the method we are sending patients very frequently home on now. And by the way, if you have any hospital systems where even nurses don't want to give depot after delivery because of the concerns, they would rather give progestin-only pills, again, the data is sort of the same across this class of medications. And so if you have patients who you know are going to become sexually active before you see them postpartum and you need to give them something, LARC methods are no worse than the methods that we're already giving these women. So how to jump over some of the nursing hurdles. First is reassurance about patient comfort. It is amazing how little a postpartum IUD hurts when given immediately postpartum. Now that's not just for women with an epidural, right? That's sort of obvious. But for moms with that newborn baby on their chest or on their breast, that endorphin release far outweighs any inconvenience you are providing to her down below by spending another 5 minutes or so getting an IUD in her uterus. And the same really honestly goes for women in the postpartum period while they're still in the hospital prior to discharge, in those the first 48 to 72 hours. I very frequently have had patients just simply watching television or sometimes texting, sometimes even breastfeeding while I'm placing an IUD. And uniformly, women have reported that the most uncomfortable part of the process is just the speculum placement. The IUD placement itself really doesn't hurt at all. Overall, it's minimal more work for staff. It's much more work for the provider to procure the devices and to get equipment together. But I very frequently will do this without staff in the room. Granted, I've always worked at teaching hospitals where I have a lot of eager learners around. But as you get used to doing these procedures, just like the office, many of us are used to working without a medical assistant, and the same can go forth on postpartum or labor and delivery. And you can reassure them about the absence of impact for the implant or IUD on breastfeeding. And it's just really amazing how fast you can convert nurses to believers. At my last institution, when we instituted this program, everyone was very disbelieving about this possibly being a good thing for patients, whether it was concerns about pain or breastfeeding or time. And within a few months, we would have nurses pulling residents aside saying, the patient in room 7, she really needs an IUD. I think you should talk to her about it. And how well they saw it worked with the placements going in so easily and implants going in without a problem, and knowing that these patients who may be lacking support at home, who may be overwhelmed by the other kids they already have, this is one lesson that they have to worry about. And nurses, just like providers, do that very quickly. So, but of course, the last challenge may be us, or more accurately, your peers, other providers, who have concerns about comfort with the procedure because this may be a brand new thing, particularly around the IUD, obviously not Nexplanon. How to get opportunities for training, their concerns about safety, particularly around expulsion, and being hesitant to spend additional time at the delivery or in the hospital when they may have a clinic full of patients that they have to get back to. And then, of course, the evergreen reimbursement concerns. So let's talk about the expulsion risk. The data in trials around IUD expulsion varies really widely. After vaginal delivery, the most common range of numbers I have seen is 5 to 30%. There's a smaller trial that looks at about 37% when talking about the postpartum period and the 2 days after delivery. We know that the risk is lower when it's placed immediately post-placental than in those 2 days after delivery, but the range of expulsion rates really vary. Cesarean delivery expulsion rates, when they're looked at separately, tend to be lower than with vaginal delivery. I suspect that this reflects fundal placement of the devices more often than not because of being in the operating room with a hand in the uterus delivering the device to the fundus, which is very different than the experience of doing it postpartum in a labor and delivery bed. Expulsion tends to be higher among levonorgestrel IUDs and the copper IUDs. This is expert consensus data, which you can take as you will, more than randomized trials of one versus the other. But this is sort of, we'll call it strong anecdotal experience that the levonorgestrel IUDs seem to have higher expulsion rates. And unfortunately, there is no data yet on best practices to minimize risk. Providers who do these procedures have their theories about what will work. And in the future, I will talk about some of those nuances about insertion to reduce expulsion risk. But as of right now, they're not evidence-based practices. So I also want to talk about cost effectiveness because this won't be just for the hospital administrators, but this will be providers as well. That the upfront costs of expulsion of the device has made a lot of people question the return on investment of postpartum LARC, that maybe this is a lot of work that we're all doing for very little ROI. And cost-benefit analyses have been done for both implants and IUDs, and in most, they have found to be cost-effective in all models, and in most models are genuinely cost savings. I've talked about 2 studies here about the implant, about the net savings per patient. In some cases is very time dependent, that the longer a woman continues the implant, the more savings there are, but also as you look further out from the initial upfront cost of the device, the cost of the insertion process, the money saved just goes up and up. That for every dollar spent on insertion, by year 3, you're saving $6.50. According to a study done at Indiana University, for every 4 patients who receive an implant during the immediate postpartum period, 1 additional rapid repeat pregnancy will be avoided. And that's an incredibly low number needed to treat 4 implants to save 1 pregnancy. And the data is pretty similar for postpartum IUDs. Despite all the concerns about expulsion, states save still on average $3 for every dollar spent on the device. And for every 1,000 women who desire a postpartum IUD, attempted immediate postpartum placement can result in a cost savings of over $250,000. And the most important number to remember of all the takeaways from today's webinar, postpartum IUDs are cost-effective until very high expulsion and discontinuation rates. Some studies it's 50%, another study it was 70%. And these are expulsion rates that are nowhere near what we've seen in the literature, even in the most dismal result studies to date about how high the expulsion rate can be. Just because an IUD being in her for any length of time reduces her risk of a rapid repeat pregnancy in those months after delivery, they are incredibly cost-effective. And it's unlikely that the expulsion rates are going to go up as time passes. I would expect that expulsion rates will go down as we discover what insertion techniques are better than others to reduce that risk. So postpartum IUDs are going to remain cost-effective and very frequently cost savings from now and going forward. So while the hurdles sometimes may seem very daunting, access to immediate postpartum LARC methods has such potential for our patients to help women achieve the family size they want, to help teen moms regain their footing, and to have a more positive outlook for their future, that I think that these hurdles can be overcome. And at this point, I am very happy to take questions.
Great. Thank you so much, Dr. White, for that excellent presentation. I will now start reading questions on the question and chat box for you to answer. Our first question is from Lily, who asks for a little more clarification on the literature regarding postpartum milk supply with LARC, including careful long-term follow-up of breast milk production and duration. So I know we talked about this a little bit in the presentation, or quite a lot in the presentation, but if there's anything else you wanted to add from the literature.
Sure. So the long-term follow-up does not go beyond 6 months, to the best of my knowledge. So they're not looking at infant growth like over the first 3 years of life per se. We find it reassuring that at 6 months there's no difference in breastfeeding rates. Some of the studies actually are very interesting. In one study, women took deuterium, which can be measured in infant saliva. And so they actually measured the deuterium levels in infant saliva and measured it via mass spectrometry to actually compare how much milk the newborns were getting. It was incredibly fascinating to actually be a way to measure, right? Because as all breastfeeding moms know, it's sometimes really hard to tell like how much the little one's actually getting. And so there's actually some hard science behind the randomized trials looking at how much milk the babies are taking in and what the quality of milk is like. I am happy to, with the materials from this webinar, post those systemic reviews and the randomized trials as easy reference for people to take a look at, because I know that in a lot of locations, trying to get nursing and lactation support on your side for this may be generally one of the biggest hurdles you have.
Great, thank you so much. Our second question is from Ava, who asks, how are postpartum insertions different from insertions after first or second trimester elective or spontaneous abortion?
Oh, good question. The first thing that actually comes to mind is that post-abortion, post-miscarriage LARC insertion is often easier to get reimbursed because these procedures are outpatient procedures, and it's actually easier. So the financial hurdle first is not quite so large with post-abortion, post-miscarriage patients. On the technical side, in the first trimester, it tends to feel very much like an interval insertion. The uterus very often contracts down to 11 centimeters or less, and so the process is not very different than what you go through for interval insertion. For second trimester procedures, so after post-abortion or post a fetal loss in the second trimester, it is sort of now somewhere in between that first trimester feels as like an interval and what a postpartum insertion feels like. The cervix remains dilated. It tends to be very easy to move the inserter in. The uterus contracting down does start to lead to what I call the hockey stick angle of the lower uterine segment going up towards the fundus. It's most pronounced postpartum. That acute angle is quite sharp and very hard sometimes to get around with instruments, easier with your hand. And in the second trimester pregnancy or after that pregnancy, it's not quite so physically difficult to do, but you definitely notice that the inserters go in, obviously much further than you're used to. The Paragard inserters often can't be used because they're too short, and copper IUDs then need to be inserted with a ring forceps after a second trimester abortion. But I'm a big proponent of ultrasound guidance for all of these, just to confirm fundal placement.
Great, thank you so much. Our next question comes from Mary, who asks, if an IUD or Nexplanon is not inserted immediately postpartum, can they be placed at any time? She was always told to wait 4 weeks on Nexplanon and 6 to 8 weeks for IUDs.
Yeah, thanks to the MEC, looking and grouping the after 10 minutes to 4 weeks as the same period and rating that a 2 where the benefits outweigh the risks, it is fine, I believe, backed by evidence, to go ahead and place it at any time, which means that if you're not able to procure the device while the patient is actually still laboring, and so you sort of miss that 10-minute postpartum window, you can still put it in while she's in the hospital. And there's no reason that you can't do it in those days after. The worry was always about perforation, about an actively contracting uterus, especially in lactating moms, increasing the perforation rate, but the Cochrane review just didn't find any evidence of an increased perforation risk. So while I always advise caution when instrumenting any kind of pregnant or recently pregnant uterus, because there doesn't seem to be an increased risk of expulsion, I don't think you have to wait until 6 weeks postpartum, which also means that a patient coming back at another time to the office may be the best you can hope for. If you can't figure out how to get IUDs or implants in the hospital, is having her come back to your office whenever it's convenient for her. So if her mom is in town for the first week, for instance, to help take care of the baby, have her come back then, well in advance of her official postpartum visit, but just for the LARC placement. So she can come back whenever it's convenient for both of you.
That's a lovely answer. Thank you so much. Our next question is from Rosie, who asks, how do you convince skeptical colleagues or leadership to integrate IPP LARC services?
That's such a really great question. I recently gave grand rounds at one of my alma maters, and my own mentor was sitting in the audience sort of shaking her head because she didn't believe that we should be doing postpartum IUD insertions because of the expulsion rate. And what I try to get to, it's just sort of like skeptical patients, right, who may be skeptical of the idea of a device inside their body, is ask what their concerns are. Because I outlined the concerns that I've heard the most often, both in my own experience and from my colleagues. But right, you can never get inside someone else's head unless you get an invitation to go in there. So ask what it is that they're concerned about. Is it purely the reimbursement issues? Because there are strategies for that. And truthfully, if you can't figure out how to get devices in your hospital, you won't be doing this yet until your state makes it easy. Is it financial? Is it physical with regards to its time and effort? And I would argue that, like anything else, once it becomes commonplace, you don't even notice the extra time, the extra equipment, because it just sort of naturally folds into whatever else you're doing. If it's training issues, I realize I didn't talk about that. There are easy postpartum models that can be created. There are videos online. There are often at conferences, there are people who are talking about these issues and sort of offering a chance to talk and to problem solve actually about how you do it. But in the end, in most cases, someone at an institution has to be the first person who's going to do it. And they may not be proctored by someone who's done it before. They may not have gone to a class. We don't really have cadaver labs for things like this. They're just going to have to do it. And so what I say is, you are used to going in the uterus all the time for retained placentas, for IUD insertions, for pipelle biopsies. You are instrumenting the uterus all the time. This is not that different than the rest of the skills. And obviously, it does take practice, and there are tricky insertions. You always want to be cautious and careful. but it's not that far out of the realm of other things that you do. And so it's try to figure out what their concerns are to address them. But that idea about reducing rapid repeat pregnancy, about increasing birth spacing, right? Healthier babies, healthier women. I feel like everybody can get behind those things.
That's a great point. Our next question is from Sue, who asks, in order to address a slightly higher expulsion rate, would you recommend a backup method for a certain period of time when the expulsion, or before the expulsion rate lowers?
Oh, good question. I wish I could say that the expulsions tended to be in the first 6 weeks. And while a lot of them are in the first 6 weeks, not all of them. Even months out, we are seeing expulsions, in the first 6 months. So I'm not sure it's fair to give someone this great forgettable method and then make them use something else on top of it for a prolonged period of time. I think that it's important to talk about the strings with postpartum IUDs. Very frequently, especially if it's placed in a C-section, you may have to have them come back to the office for the strings to be trimmed because they may not stay curled nicely up at the top of the vagina. So talking to patients about what happens if they feel the strings, about not pulling on it, about tucking it back inside, about coming to you, about maybe being aware of the strings during this high expulsion risk period. Most of us don't make our patients do monthly string checks anymore, but maybe for postpartum insertion patients, that's not a bad idea.
That's a great idea. We are just waiting for a couple more questions to come in. I can answer the next one, which is asking if the presentation is recorded, and the answer to that is yes, and I'll go over a few more details on that when I conclude the webinar in a few minutes. So we'll just see if there are any other questions from our audience right now.
I will say I'm just going to highlight my coming attraction slide. When we sat down to set up this webinar, ARHP and I, we realized that there were so many topics to discuss that it was really not possible to put them all into 1 hour. So instead we divided it up into 2, that today was going to focus on the data and some of the obstacles to starting a program, and the next webinar about, well, how do you actually do it? How do you set up a program at your institution? What are the elements of a training program? How to get allies at the various levels of the hospital to help you with this efforts, and then actually how to place immediate postpartum IUDs during all the time periods that you can place one, meaning at the time of vaginal delivery, at the time of cesarean delivery, in the days postpartum after either, talking about ultrasound use, various techniques, and clinical pearls and things like that. So while I'm happy to answer questions about any of these things right now, we are preparing another hour to address them in depth as well.
Perfect. Thank you so much. Lori asks, is the risk of missing strings higher with IPP IUDs, and would this make IUD removal more difficult in those populations?
I think the risk of missing strings is higher at cesarean delivery, especially with an unlabored cervix, because it might be difficult. And some providers with all unlabored cervixes will take a ring forceps from above and open up the cervix to allow the lochia to flow. It's not really evidence-based, and so I think more younger providers are not doing that as routinely. You do want to try to get the strings out to the cervix down below, but it might happen less with cesarean deliveries, and that then would sort of necessitate a little extra effort at the time of removal, whether with a hook or with an alligator forceps. With vaginal deliveries, you tend to cut the strings flush with the cervix, so you can still see the strings come out, but a very little bit. That ensures that when the uterus involutes and the IUD starts to sort of lower and the strings get longer, that the strings aren't too long. So I think I haven't seen nearly as many retained or retracted strings after a vaginal delivery. On par, though, in my experience, it's very much like interval, where there are just missing strings for no good reason that require more effort to remove. And then there are the cases where the strings go back and forth, up and down, and remain a mystery.
Great, thank you so much. Our next question is from Rhonda, who asks, do you have a sense if IPP LARCs are being placed at federally qualified health centers or community health centers?
I don't know if, I think there's fewer barriers as soon as a woman is outpatient, but that idea about making the visit protocols easier, like that idea about 72 hours after hospital discharge, coming back for an IUD, I don't know if centers widespread. We know there are still a lot of obstacles with things like 2-visit protocols that are required, where people get consented and sort of screened for a device one day and then get the device the next time. And so I don't have a good global sense of what the federal health qualified centers are doing with regards to the postpartum front. I'd like to think that they are also being creative, that if patients can't get the IUD or the implant in the hospital, that they're dropping barriers to them getting it as an immediately discharged postpartum patient, but I actually don't know.
Perfect. Thank you so much. Is there anything else from the coming attractions that you'd like to share before we move on to our key points?
No, I think I'll just tease everybody to come listen to the next one. All right, so takeaways from today. So you can assure your colleagues and your staff at your hospitals that immediate postpartum LARC is a safe approach for postpartum contraception, backed by a lot of evidence, both from around the world and a lot of U.S. data, which is actually all the data that I presented today. It's incredibly convenient for both patients and providers. It minimizes the risk of rapid repeat pregnancy with all the health complications that can arise after that, and it really assists women in spacing their pregnancies. There's no increased risk of device insertion beyond the risk of interval insertion and the risk of expulsion, but nothing with around infection or perforation or things like that. And there's right now no impact on breastfeeding. So immediate postpartum LARC feels like one of those win-wins across the board, that women get what they need when they need it. And as a society, we are helping to support women and the families that they want and when they want them, which leads to healthier moms and babies. So I really do hope that you learned something today and that you'll consider taking this on as a mission, perhaps in the new year, to seeing what your state allows with regards to Medicaid financing of immediate postpartum LARCs, or listening at future events or at conferences about how other people have managed to work around whatever their state is doing to bring this great thing to their patients.
Perfect. Thank you so much. And thank you again for joining us, Dr. White. Before we end today's webinar, I'd like to share a few additional reminders. In about an hour, you will receive an email from Caitlin Forswitz containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing your internet browser. If you have questions, just email us at education@larhp.org. As I mentioned earlier, a recording of today's webinar will be posted shortly on arhp.org. arhp.org is also where you can find recordings of the previous webinars in this series, and we encourage you to sign up for the next webinar in this series on November 10th. Thank you all for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.